Assalamu alaikum. How's everybody doing? We will be talking about the elbow joint and forearm in this lecture. You can view the elbow joint as a complex joint, meaning it involves three separate articulations. And these three separate articulations, that's number one, between the head of the radius and the capitulum. That's number two, between the ulna and the trochlea. That's number three, between the proximal radius and ulna. So these three separate articular surfaces are actually sharing a common synovial cavity. All of them are enclosed within one cavity. Right? The joint which is between the trochlear notch of the ulna, right, and the trochlea of the humerus, and the joint which is between the head of the radius and the capitulum are primarily involved with hinge-like flexion and extension movements of the forearm on the arm. And these are, you can say, the principal articulations that forms the elbow joint. On the other hand, the joint that is between the head of the radius here and the radial notch on the lateral surface of the proximal ulna, they form the proximal radio-ulnar joint, and that is involved with pronation and supination of the forearm. Right? So actually the elbow joint, you can take it as one unit. It performs the following actions, that is flexion and extension, pronation and supination. Right? Now, you can also view, these are the movements, right? Flexion and extension movements. These occur at the radiocapitular and humero-ulnar joints. And pronation supination movements, as you can see, they occur at the proximal radio-ulnar joint, or at least proximal radio-ulnar joint is involved in it to some degree. Now, the synovial membrane of the elbow joint, it originates from the edges of the articular cartilages and lines the radial fossa and also the olecranon fossa and the coronoid fossae, right? All of these fossae that we've talked about, the synovial membrane lines them. And it has some clinical importance. I will tell you that in a moment. The synovial membrane, which is here, it is drawn here if you can see it, that's the synovial membrane. It is basically separated from the fibrous membrane of the joint capsule by fat pads in the regions of the these fossae, coronoid, radial, and olecranon fossae. Do you see these fat pads? They are separating the synovial membrane from the overlying capsule, which should be here. It's removed, the fibrous capsule of the joint. And the function of these fat pads is to accommodate the related bony processes during extension and flexion of the elbow. The brachialis and triceps brachii muscle attachment to the joint capsule overlying these regions, they pull the attached fat pads out of the way during flexion and extension movement so that the bony processes can accommodate into these holes. You get that idea? That's why I've told you earlier that brachialis inserts into the capsule of the joint, but also it pulls these fat pads upwards. Similarly, triceps brachii from the back, it also inserts into the capsule of the joint. And thus when it contracts, it will pull the fat pad overlying or covering the olecranon fossa, which is from behind. We can't see that. But also it has similar function that during extension, it extends the arm, but at the same time it removes this fat pad out of the way. The other importance is that during effusion, any process where there's joint effusion or hemarthrosis of the elbow joint, these fat pads, of course, the bleeding occurs or the effusion occurs underneath these fat pads. And they will be elevated away from their relative fossae. And it appears the fossa here will appear as a radiolucent region called fat pad sign. This is referred to as fat pad sign, right? It indicates effusion, something in the joint. Is that right? Okay. The fibrous membrane of the capsule, that is, of the joint capsule, it is covering the synovial membrane, right? It is overlying the synovial membrane, as you can see, and covering it, and encloses the joint, and it also attaches, as you can see here, to the medial epicondyle and also to the margins of the fossae that we've talked about, right? To the margins, and also to the lateral epicondyle of the humerus. From the back, we can't see that, but also from the back, it attaches to the coronoid process of the olecranon of the ulna. This fibrous membrane is thickened in particular regions. It's thickened medially here to form a ligament, which is called the ulnar collateral ligament, right? And this prevents excessive abduction of the joints. It stabilizes the joint. And also laterally, it is also thickened to form the radial collateral ligament, and that prevents excessive adduction of the joint, right? Excessive, you can say valgus stress, varus, it should be varus. Excessive varus stress or adduction stress on the joint. Similarly, the ulnar collateral ligament prevents excessive valgus stresses on the joint. That is, abduction stress on the joint. Additionally, the external surface of the joint capsule is reinforced laterally, where it cuffs the head, you can say, of the radius. This is called the annular ligament of the radius, right? It cuffs the head of the radius, actually, yes, it goes to the back side, right? It attaches to the ulna here and then goes from the back side and also attaches to the ulna, right? But from posterior aspect. And that keeps the head of the radius against the radial notch of the ulna and stabilize the proximal radio-ulnar joint. Now, it allows the pivot movement of the radius or rotatory movement of the radius upon the ulna. In fact, this has also some clinical importance, nursemaid elbow. Of course, you've heard about that's a famous condition called nursemaid's elbow, or called pulled elbow. And that's very common where children, if they are brusquely elevated or pulled from their hand or forearm, it exerts traction force on the radial head and basically pulls the radial head out of its position and the cuff of the annular ligament. And the baby or the child presents with pain, inability to move the joint, and it is a very common condition, and it is usually managed. That is diagnosed on clinical grounds only, and also managed right away without having to have any sedation or anesthesia or anything. That is managed with either hyperpronation movement technique or flexion, that extension flexion technique. These are that's a topic for orthopedic surgery, but that's something to mention here about the radial or annular ligament of the radius. Yes, the vascular supply of the elbow joint, it comes from the surrounding anastomotic network of vessels, which are derived from the collateral and recurrent branches, if you remember, from the brachial, from the profunda brachii artery, from the radial and ulnar arteries. The collateral and recurrent branches that we've talked about, these form an anastomotic network around the elbow joint and supplies it. Innervation is predominantly by branches of the radial and musculocutaneous nerve. So basically, the radial nerve and the musculocutaneous nerve are the predominant nerves that are supplying the elbow joint. But there may also be some contributory branches from the ulnar and median nerves as well. All right. Good. Let's now move to the Cubital fossa. It is a very important region in the exam, the cubital fossa. Very important area of transition between the arm and forearm. And it is located, it looks like an inverted triangle pointing downwards, and it is on the anterior aspect of the elbow joint. And it is formed by the muscles. It is a triangular depression here formed by the surrounding muscles. You've got on the lateral aspect is the medial border of the brachioradialis. This muscle here, this is called brachioradialis. Actually, the medial border of this muscle, it forms the lateral border of the cubital fossa. So that's one border, right? Brachioradialis. That's the lateral border. The medial border is the lateral border of the pronator teres. Right? That's a muscle of the anterior compartment of forearm. We'll talk about it shortly. It's called pronator teres, a powerful pronator of the forearm. And the lateral border of this muscle is the medial border of the cubital fossa. The superior border is an imaginary line which is extending or stretching between the medial and lateral epicondyles of the humerus. Right? The contents of this fossa, or the major contents of this fossa, from lateral to medial, you can remember them as tan. Right? From lateral to medial, you can remember this as tan, which is, let's zoom in, try to zoom in a little bit. The tendon of the biceps brachii, that's the most lateral content. So this one is the first content, which is the tendon of the biceps brachii muscle. Then just next to it, or just medial to it, is the brachial artery. This is just medial, immediately medial to the tendon of the biceps. And immediately medial to the brachial artery is the nerve, which is the median nerve, right? That's the third content. So basically you have three contents. Tendon of the biceps brachii, that's the most lateral. Just next to it is the artery, the brachial artery, and just next to that is the median nerve. You can remember it as tan. These are the contents of the fossa. The brachial artery normally bifurcates into radial and ulnar at the apex of the fossa, about the level of the radial neck of radius, which is hidden here under the brachioradialis. About that level, it will bifurcate into radial and ulnar arteries, as you can see, at the apex of the fossa. Okay? But you have to remember that this is variable anatomy, because this bifurcation may occur at a much higher level than this. Actually, in some of the people, this bifurcation can occur in the upper arm. In other people, it can even occur in the axilla. Can you remember that? Can you really believe that? So it can actually occur very high up in the axilla. It bifurcates very soon. That there's no brachial artery. That the axillary bifurcates into radial and ulnar. So highly variable anatomy. There's nothing 100% about anatomy. The median nerve, how does it exit the fossa? The median nerve, of course, it is lying in the distal part of the arm. It is lying just medial to the brachial artery. Now look, this is the brachial artery dividing, as you can see, into its radial and ulnar branches. And look carefully now. Look at this median nerve. The median nerve, you know the muscle that I was telling you about, the pronator teres? It actually has two heads. It has a superficial head here, which we call it humeral head, which is this one. This is the humeral head of the muscle, right? And it has been cut in this position, has been cut away to reveal the deeper head. This deeper head, it comes from the ulna, and it is called the ulnar head, right? So it has two heads. Now, the median nerve passes between the two heads of the pronator teres. Is that right? Now it is passing in between the two heads of pronator teres. It means it is deep to the humeral head and superficial to the ulnar head. Is that right? Now look at the ulnar artery on the other hand. The ulnar artery passes deep to the deep head of pronator teres. It passes deep to the ulnar head. It means that the median nerve and the ulnar artery, they are separated by the ulnar head of pronator teres at the distal end of the cubital fossa, as they are exiting the fossa, I mean. Right? That's a very important point about that. If you go back, there's another detail that I want to also highlight. The brachial artery and median nerve, they are covered by this thing, right? This extension from the biceps brachii tendon. And that is, of course, we know that that's called bicipital aponeurosis. Is that right? Aponeurosis means flat tendon in anatomy. Now, this flat tendon or aponeurosis, it is covering and protecting the brachial artery and the median nerve here. And it is going medially. It is going medially, and at some point it will just blend with the deep fascia of the upper limb. It will just blend and becomes as one unit with it. Just amalgamate with it. Okay? So this bicipital aponeurosis partly forms the roof of the antecubital fossa or cubital fossa, right? Because it is going superiorly and blending with the overlying deep fascia. It will actually form part of the roof, large part of the roof, right? The radial nerve, it is not a content of the fossa, but it is related to it. Now, if you actually go to this diagram, in this diagram, the brachioradialis have been pulled laterally, right? If you pull the brachioradialis laterally, you will see the radial nerve just deep to it, just under the lip of the brachioradialis, right? That forms, of course, we know this forms the lateral margin of the fossa. The radial nerve, it is moving here, and it is going to supply branches to the brachioradialis, right? It will also divide under the brachioradialis, as you can see. It is dividing into two branches under cover of the brachioradialis. This branch is called the superficial branch. Superficial radial nerve. And that is sensory nerve. That's a sensory nerve. And we will follow its course in the forearm and hand and see what does it do there. But for now, just trust me, this is purely sensory, and it is actually supplying an area, the lateral dorsum of the hand. On the other hand, the other branch, which is this one, that is referred to, it's a very short nerve, and that is referred to as the deep branch of the radial nerve, and that's motor. Now, what's going to happen to this nerve? There is a muscle deeply sited here, right? This muscle, this one, that is called supinator. This muscle is called supinator. And the supinator has two heads. Anyway, we'll talk about it. Now, this is one head of the supinator, and this is another head. I don't know if you can see that clearly, but it does have two heads. Now, the deep branch of the radial nerve is passing between the two heads of the supinator. And it's actually, you can say, twisting posteriorly to enter into the posterior compartment of the forearm. We will follow and see exactly how does that happen later. I just wanted to show you what will the radial nerve look at the level of the cubital fossa, which is not, of course, a content of the cubital fossa. You have to realize it's not a content of the cubital fossa. It is just under its lateral margin, which is the brachioradialis. The ulnar nerve does not pass in relation to the cubital fossa at all. The ulnar nerve is passing posteriorly. Here's the ulnar nerve. It is passing behind the medial epicondyle here in a tunnel, which is called the cubital tunnel. And we will see what's gonna happen in the forearm when we follow its course there. Now, the roof of the cubital fossa. This diagram shows us the roof of the cubital fossa. Actually, the roof is formed by superficial fascia and skin, okay, and then deep fascia. The most important structure that is within the roof is the median cubital vein. Do you see this is the vein? Median cubital vein. It is coursing through the roof of the cubital fossa, and it is connecting the basilic vein here, which is medially located, to the cephalic vein, which is laterally located, right? And that's actually the median cubital vein in between them, right? So it's a structure over the roof or passing over the roof of the cubital fossa. The bicipital aponeurosis, right? That's a question in the exam. Is the structure which is separating the median cubital vein from the brachial artery and median nerve, which is underneath, right? It's the bicipital aponeurosis. The other structures which are here, they are actually cutaneous nerve, the medial cutaneous and lateral cutaneous nerves of the forearm. That's the lateral cutaneous nerve of the forearm, as it is piercing the deep fascia here and passing onto the roof of the cubital fossa. That's the other structure at the roof. And the medial cutaneous nerve of the forearm, which is, what's that? That's a branch of the medial cord, if you remember, medial cord of brachial plexus, right? Remember that? And the lateral cutaneous nerve of forearm is the continuation from the musculocutaneous, right? Now, both of these structures, they are at the roof of the cubital fossa. So what are the structures at the roof? Number one, median cubital vein. Number two, lateral cutaneous nerve of the forearm. And number four, medial cutaneous nerve of the forearm. Basically, that's what the cubital fossa is all about, right? I hope it is clear. Now, if we move to talk about the forearm, simply the anatomical definition of a forearm is that part of the upper limb which extends between the elbow and wrist joints, right? This section is called forearm. Everyone knows that, of course, right? So this section, which is between the elbow and wrist, is the forearm. From the proximal extent, the structures which are coming from the arm and entering into the forearm, majority of them, they pass either within or in relation to the cubital fossa. This includes the brachial artery, the ulnar nerve, the median nerve, and the radial nerve. The majority of the structures enter in this way. Right? The exception here is the ulnar nerve. The ulnar nerve does not pass in relation. It actually passes posterior to the medial epicondyle of the humerus. And distally, many of the structures, they leave the forearm and enter into the hand through the carpal tunnel or anterior to the carpal tunnel. Right? The major exception for that is the radial artery, which does not pass through the carpal tunnel or anterior to it. It actually passes dorsally around the wrists to enter the hand posteriorly. Of course, we'll see all of that. Just I'm giving you an overview. If you take a cross section in the forearm, in the middle part of the forearm, there are two bones forming the forearm. Medially, that's the ulna, right, which is triangular in shape. And laterally, that's the radius, which is also somewhat triangular in shape. Now, the ulna and radius, they are interconnected together by the interosseous membrane. And this membrane is attaching to these borders of these bones. And these borders are actually called the interosseous borders. This border of the ulna and radius. These are called interosseous borders. The posterior border of the ulna here, it is actually directly attached to the deep fascia. So actually you can palpate the posterior border of the ulna throughout its length. Right? That's the deep fascia attaching to the posterior border of the ulna, wrapping around the upper limb, and then coming back to attach to the ulna again. That's why you can feel the posterior border of the ulna throughout its length. Now, you can also see that because the ulna and radius are attached to each other here at the interosseous membrane, and also there's an intermuscular septum, right? There's an intermuscular septum which is attaching to the anterior border of the radius and blending with the deep fascia. That is going to split the forearm into two compartments, an anterior compartment and a posterior compartment. Basically that's the structure, the overall structure or bony skeletal framework. If we go, we don't need much details about the bony anatomy, but anyway, the head of the radius, we've already talked about the head, neck, and radial tuberosity. Here is the oblique line. Do you see that's the oblique line extending down from the radial tuberosity across the bone, forming a sharp anterior margin of the bone here, the oblique line. This is the anterior border of the radius, that's the anterior surface, that's the interosseous border, this is the posterior border, posterior surface, and then posterior border, and then the lateral surface is somewhat curved like that. Just lateral to the oblique line here, there is a roughening in the middle section of the bone for the attachment of the pronator teres muscle, as we will see, right? The distal end of the radius is a little bit interesting. It becomes flattened. It doesn't become, at first it's somewhat triangular, but at the distal end it becomes more broad and flat. So as you can see here, if you view it as a distal view, you can see that it is flattened anteroposteriorly and it is becoming more broad. The distal end of the radius here is extending as a process laterally, and this is called radial styloid process. And then on the medial end there is an articular surface, right? And that's for the distal end of the ulna, right? The distal end of the ulna, that's the other side of it, but from behind. So it's kind of like a notch so that the distal end of the ulna can fit to form the distal radio-ulnar joint. On the distal view, there are two articular surfaces for the radius. A lateral facet for the articulation with the scaphoid bone, and a medial facet for the articulation with the lunate bone, as we will see in the hand, right? So actually the distal radius is articulating with two of the carpal bones in the proximal row, the scaphoid laterally and the lunate just next to it medially. From the back of the distal radius in a posterior view, there is a raised piece of bone, and this is called Lister tubercle, or the dorsal tubercle of the radius. And this is an important structure because it separates some of the tendons that are passing here. And I will show you the details later. Okay, just keep it in mind that there is a raised piece of bone in the dorsal aspect of the radius, and that is called Lister tubercle or dorsal tubercle. If we take a look at the ulna, the distal end of the ulna doesn't have a lot of features actually to it. The distal end is smaller than the proximal end. It has a styloid process which is directed posteromedially. That's the styloid. This is much smaller than the radial styloid and extends less distally. It means that the radial styloid extends more distally compared to the ulnar styloid. This surface of the bone, the distal end of the bone, it does not articulate with any of the carpal bones. Actually, there is a cartilage, a piece of cartilage here, which is called the triangular cartilage, which separates this triangular cartilage. It separates the distal end of the ulna from the carpal bones. So, in other words, the distal end of the ulna does not directly participate in the formation of the wrist joint. That's the point that I wanted you to know. If we can go to the next, which we'll see them together, the two bones together, fitting together. As I've told you, in the distal end, the radial styloid extend much more distally compared to the ulnar styloid. That's why you can take your hand into adduction or ulnar deviation more than you can take it into abduction or radial deviation. You can also try it on yourself, right? You can take your hand in to a much greater degree than out, right? This is the articular disc that I've been telling you about. Do you see that? This is the one that is attaching to the ulnar styloid here and then to the radius on the other hand, and it is separating the ulna from the carbus, right? And here is the radius. This is the scaphoid. This is the lunate, right? So the scaphoid and lunate are the ones that are articulating. The triquetrum does not, except in extreme, yes, if you, that is, extremely adduct the hand into ulnar deviation, the triquetrum, which is the next bone here, may touch the radius. On top of the triquetrum, there's the small sesamoid bone, the pisiform, right, which is the sesamoid bone in the tendon of a muscle called flexor carpi ulnaris. This is the interosseous membrane, which largely extend downward from the radius, from the interosseous border of the radius to the interosseous border of the ulna. There is an upper free margin where structures can pass from and to the anterior and posterior compartments of the forearm. And there's also a distal aperture here where structures can also move to and from the posterior and anterior compartments of the forearm. Right, that's the basic structure here. If we want to talk a little bit about that is pronation and supination. Pronation and supination of the hand, they occur entirely in the forearm. It means that the hand, or that is the arm, does not participate in this movement. This movement entirely occurs in the forearm. And it involves rotation of the radius at the elbow proximally, and not only that, movement of the distal end of the radius over the ulna. So look again, the proximal end of the radius, it just rotates on the ulna, right? It rotates on the ulna at the proximal radio-ulnar joint. Distally, what's going to happen? The distal end of the radius here, it jumps over the ulna. It jumps over the distal end of the ulna. This is what the movement entails, the movement of pronation. Again, at the elbow, the superior articular surface at the elbow, the superior articular surface of the radial head spins on the capitulum, right? It spins on the capitulum, while at the same time, the articular surface on the side of the head, slides against the radial notch of the ulna and adjacent areas of the joint capsule and annular ligament of the radius. At the distal radio-ulnar joint, the ulnar notch of the radius slides anteriorly over the convex surface of the head of the ulna. Okay? Anyway, this is in more details. The muscles which are involved here. But I want to also highlight another detail. When the radius jumps over the ulna abducts. The ulna abducts. Is that right? The ulna actually abducts. It's medial here, but there's a muscle which pulls the ulna into abduction. And this movement is important because it keeps the hand in the same plane. So look, if this is a supinated hand, suppose we take this line extending from the distal end of the ulna, right? And this is the plane that we want to use. During pronation, the plane does not change. It means the center of the hand remains in the same location in pronation and supination. This is only possible if the ulna abducts under the radius. Right? That's the trick behind why the ulna abduct. The muscles which are involved in pronation are basically two muscles. The biceps brachii, which is the strongest supinator, right? It is the strongest supinator. It's a very powerful supinator as well as a flexor of the elbow joint. And it is most effective as a supinator when the forearm is flexed. In the flexed position, if the forearm is pronated, the strongest muscle which can supinate the forearm at this location is the biceps brachii. The next muscle for supination is called the supinator, which is this one. The supinator muscle attaches to the radius anteriorly here and then wraps posteriorly. It has two heads, one head attaching to the humerus and the other head attaching to the ulna. So it's actually wrapping behind the bones. And it is considered as a muscle of the posterior compartment of the forearm. Okay? The supinator is also an important muscle of supination. However, it is less powerful than the biceps brachii. The muscles of pronation are two muscles, which are pronator teres and pronator quadratus. Okay, the pronator teres, which is this one, it originates from as two heads also, from the humerus and ulna. And then it attaches to the mid shaft of the radius laterally, on the lateral surface of the radius, beyond the oblique line, right? And when it contracts, it will bring the arm into pronation like this. The forearm into pronation like that. The other muscle of pronation is the pronator quadratus, which is in the anterior compartment, deep anterior compartment of the forearm. And it just attaches to the front of the radius on one side and the front of the ulna on the other side. And it is just a muscle of pronation. But it is, of course, less strong compared to the pronator teres. So you've got two muscles of supination and two muscles of pronation. The two muscles of supination are biceps brachii and supinator, and the two muscles of pronation are the pronator teres and pronator quadratus. Now let's talk about the anterior compartment. That's the function of anconeus. Do you see? The muscle that I've told you that it abducts. That's another muscle. We will talk about it in details later. But just note right now by name that the function of the anconeus is abduction of the ulna, right? Abduction of the ulna by anconeus during pronation. And that is what is keeping the center of the hand in the same location. Whether the hand is pronated or supinated, it always remain in the same, the axis will always remain in the same position. Now let us take a look at the anterior compartment of the forearm. First, let's talk about the muscles. Generally, the muscles in the anterior compartment of the forearm, which is also called the flexor compartment, right? They occur in three layers. There are three layers to it. There's a superficial layer, and there's an intermediate layer which contains one muscle, and then there is a deep layer. In general, these muscles, they flex the wrist and fingers, they flex the thumb, and they pronate. They pronate in general, okay? And in general, all of those muscles in the superficial, intermediate, and deep layers, they are supplied by the median nerve, except the flexor carpi ulnaris, flexor carpi ulnaris, that's one muscle, and the ulnar half or medial half of flexor digitorum profundus. Only these two muscles, but the rest of the muscles are supplied by median nerve or branches thereof. The flexor carpi ulnaris and the medial half or ulnar half of FDP, that is flexor digitorum profundus, are supplied by the ulnar nerve, branches from the ulnar nerve. So this is the flexor carpi ulnaris. Do you see? The flexor carpi ulnaris, which is one of the muscles in the anterior compartment of the forearm, in the superficial layer, that is supplied by the ulnar nerve. The flexor carpi ulnaris is also the most medial muscle. It is the most medially located muscle in the superficial layer of these flexors. And it have a long linear origin. It actually originates as two heads, right? There is a humeral head. Do you see? Humeral head of flexor carpi ulnaris, which originate from the medial epicondyle of the humerus. And then it has a long linear origin from that is the olecranon process of the ulna and the posterior border of the ulna. Right? This is called the ulnar head. Now, this deeper ulnar head and the humeral head, they merge into one muscle. And it then forms a long tendon which passes distally, and then it attaches to the pisiform. It attaches here to the pisiform bone. And then from the pisiform, there are two ligaments. There are two ligaments which emerge from the pisiform. You've got a ligament here which is called pisohamate, and another one which is called pisometacarpal. Now, this pisohamate, it attaches the pisiform. Maybe we can clear the view. This pisohamate ligament, it attaches the pisiform to the hamate bone, which is this bone, the hamate, which is one of the carpal bones in the distal row, right, of the carpal bones. That's one ligament. The other ligament is called pisometacarpal, which attaches it to the base of the fifth metacarpal. So metacarpal bones, actually, we count them from lateral to medial. This is the first, this is the second, that's the third, this is the fourth, and this is the fifth. So actually, it attaches to the base of the fifth metacarpal. So it does attach to the pisiform, but also indirectly to the hamate bone and base of fifth metacarpal by the pisohamate and pisometacarpal ligaments respectively. And this muscle is supplied by ulnar nerve, right? Ulnar nerve. The function of this muscle is flexion at the wrists. That's one function. Flexion at the wrist. The other function is ulnar deviation, or that is adduction of wrists. It also has an interesting relationship with the ulnar nerve. Do you see, we followed the course of the ulnar nerve in the hand, in the arm, and we said that it is, let's recap, the ulnar nerve originates as a continuation of the medial cord of the brachial plexus. And it keeps a medial relationship to the brachial artery throughout its length in the arm. And then somewhere in the distal arm, it penetrates the medial intermuscular septum and then passes to the posterior compartment of the arm, behind the medial epicondyle of the humerus. Here it is in a tunnel called cubital tunnel. And then from here, it is going to pass forwards between the two heads of the flexor carpi ulnaris to enter into the anterior compartment of the forearm. So that's another special relationship. So you can summarize the nerves which are passing across the elbow joint. How do they enter the forearm? The ulnar nerve enters between the two heads of the flexor carpi ulnaris. The median nerve passes between the two heads of the pronator teres, and the radial nerve passes between the two heads of the supinator. Is that right? Okay, that's one muscle. The next muscle, so these are the next muscle with the flexor carpi ulnaris intact. Just next to the flexor carpi ulnaris, there's a variable muscle which is absent in 15% of the population, which is called palmaris longus. It's not present in everyone. This muscle originates from the medial epicondyle of the humerus superiorly, passes downwards, and it inserts where? It passes down and inserts into the palmar aponeurosis, right? It's a thick band of connective tissue or sheet of connective tissue in the palm of the hand. It is triangular somewhat in shape. The apex of the triangle here is attached to the palmaris longus. Now, if palmaris longus is not present, the apex of the palmar aponeurosis attaches to the front of the wrist, right? In an area called flexor retinaculum, right? In the front of the wrist. Anyway, the palmaris longus, like all of the other muscles, is supplied by the median nerve. The function of this muscle, first, it can flex the the wrist joint because it's attaching beyond the elbow, the wrist joint, so it can flex the wrist joint. Additionally, because the palmar aponeurosis anchors the skin of the hand, contraction, it anchors the skin of the hand at the palm, so contraction of this muscle, resists shearing forces when gripping. When you grip an object, it increases the strength of the grip, or the cup of the hand. It deepens the cup of the hand so that you can grip objects better, right? That's the function of palmaris longus muscle. Just next to it is another muscle which is called flexor carpi radialis. This one, that's flexor carpi radialis. The flexor carpi radialis, it originates also from the medial epicondyle of the humerus. So you can say that the flexors have a common origin from the medial epicondyle, right? The humeral head of flexor carpi ulnaris, the palmaris longus, and the flexor carpi radialis. They are all coming from a single tendon, you can say, or common flexor origin from the medial epicondyle. They call it common flexor origin, right? They all are coming from the medial epicondyle. The flexor carpi radialis moves distally as a long tendon. It moves distally and inserts at the basis of the second and third metacarpals. So this is first, second, third is hidden under here, but it's attaching to the second and third at the basis, right, of the second and third metacarpal bones. It is also supplied by the median nerve, of course, right? The function is flexion of the wrist, but also radial deviation of the wrist, that is abduction. So the flexor carpi ulnaris here was adducting the wrists, but the flexor carpi radialis, it abducts the wrist, abduction, abduction of wrist. Finally, you've got the pronator teres in the superficial layer. The pronator teres, it has two heads, right? As I've told you earlier, it has two heads. One head, it is coming from the humerus, from the medial epicondyle of the humerus, and also medial supraepicondylar ridge. This is called the humeral head. The ulnar head, it is deeper. The ulnar head, it originates from the medial side of, you remember this process? Coronoid process of the ulna. Remember that? This is called coronoid process of the ulna. It is coming from the medial side of the coronoid process of the ulna. The two heads converge into one flat tendon. And this tendon, it inserts onto the lateral surface of the radius, in the mid-shaft of the radius, lateral to the oblique line of the radius. That's the oblique line of the radius. So it is lateral to it, mid-shaft of the radius, lateral surface. Again, it is supplied by median nerve. And the function, as we know, pronation, right? So that was the superficial layer, the muscles in the superficial layer of the forearm. You can, let's review them really quickly. All of the muscles in the superficial layer are supplied by the median nerve except flexor carpi ulnaris. In succession, from medial to lateral, you've got flexor carpi ulnaris, followed by palmaris longus if present, followed by flexor carpi radialis, followed by pronator teres, right? the majority of them either completely or partly originate from the medial epicondyle of the humerus, right? The exception is that the humeral head of the pronator teres additionally originate from the supraepicondylar ridge, medial supraepicondylar ridge, and also from the medial epicondyle. And its deep head comes from the medial aspect of the coronoid process of the ulna. The other exception is the ulnar head of flexor carpi ulnaris, which originate from the back of the olecranon and posterior border of the ulna, right? That's the thing about them, the muscles in this layer. Then, if you remove all of these muscles and look what's in deeper to them, you will see one muscle. This big one muscle here, right? This big muscle is called the flexor digitorum superficialis. So the flexor digitorum superficialis is actually, that's the only muscle which is forming, yes, the intermediate layer of the forearm. Now, the flexor digitorum superficialis originate as two heads. This head is combined. It's called the humero-ulnar head, humero-ulnar, because it originates from the medial epicondyle of the humerus on one side. So this is the origin from the medial epicondyle of the humerus and the coronoid process of the ulna, right here, the coronoid process of the ulna. So coronoid process of ulna. So it's actually two combined. So that's why it's called the humero-ulnar head. The other head is the radial head. The radial head, it originates from the oblique line, you can say, of the radius, right? Oblique line of the radius. So the humero-ulnar head and the radial head come together to form four tendons. And these tendons, they enter through the carpal tunnel. These tendons are actually, they are on top of each other. So you have two tendons here in front and two tendons under them, right? So they are not arranged as a row, they are arranged vertically on top of each other. And they will enter through the carpal tunnel. And then they will fan out. Once they enter into the hand, they will fan out into the four medial fingers, right? And once they enter here, opposite the, what is that? That's the proximal phalanx. This is the middle phalanx. And this is the distal phalanx. Opposite the proximal phalanx, they will split. Do you see? They split. Each tendon split into two little tendons. And these two little tendons insert on the sides of the middle phalanx. Of the middle phalanx of the index finger, of the middle finger, of the ring finger, of the little finger. That is, of the medial four fingers. Now this split actually has a purpose. We'll see a muscle in the deep layer of the anterior compartment of the forearm that passes in between these two splits, which is, yes, FDP, flexor digitorum profundus. The function of this muscle, which is supplied by the median nerve, the function of this muscle is flexion of the proximal interphalangeal joints, right? So because this is the proximal interphalangeal joint, right? Because this muscle inserts into the middle phalanges of the medial forefingers, sorry, it can act on the proximal interphalangeal joints, right? So it flexes the proximal interphalangeal joints. It flexes these joints, which are the metacarpophalangeal joints, and it flexes the wrist joint, right? So this is the muscle in general. Now I want to also add a note that the majority of the muscles which flex the fingers, and that is flexion of the fingers, the majority of these muscles which are responsible for the strength of the grip. Now listen carefully, they love this in the exam. Responsible for the strength of what? Of the grip. Now look, the intrinsic muscles of the hand, these small muscles in the hand which originate and insert in the hand, They are not responsible for the strength of the grip. They don't have anything to do with the strength of the grip. Okay? They are important for the small precision movement of the hand. But the long flexors that we are talking about right now, these are the ones that are responsible, the ones that enter the hand. These are the ones that are responsible for the strength of the grip. These muscles are predominantly supplied by C8 nerve root. Now go back to the brachial plexus. Remember, this is C5, C6, C7, C8, T1. Remember, C8 and T1 were forming the lower trunk, and then the anterior division was continuing here as the medial cord. And then the medial cord gives ulnar nerve and gives medial root of median nerve, right? And then, of course, there's a root from the lateral cord, which then forms the median nerve. The median nerve here is carrying these C8 fibers along all of these way. So it means if in the exam they give you a case which has weak grasp, weak hand grip, there is a problem with C8 nerve root. Or some part of the brachial plexus which is carrying C8 nerve roots. This is so important, okay? Anyway, yes, so that's it for this lecture. In the next lecture, we'll be talking about the deep layer, which contains basically two muscles, the flexor digitorum profundus, three muscles, sorry, flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. Thank you everyone for listening, and best of luck.